Welcome, folks, to Interoperability Roundtable. This is an open forum fostering conversations around interoperability. I'm Jake Tunney, Business Development and Product Manager for Leap Orbit, focusing on our Provider Data Hub product Convergent, and I will be your MC today. Interoperability Roundtable is sponsored by Leap Orbit. Leap Orbit is the trusted innovation partner to many of the biggest market-leading health data networks, including CRISP, Manifest Medics, and Sync Health, as well as the policymakers who oversee them. And we're currently working on improving the accuracy and accessibility of provider data with our product Convergent, Provider Data Hub and API as a service. And today we're joined by Provider Network Executive Loretta Haythorn. Loretta is going to help give us a holistic view of delegated roster management and why it's so important within the healthcare insurance enterprise. But first, before she jumps in, let's give a little bit more background about Loretta. Loretta is a dynamic healthcare leader with extensive experience in all aspects of provider network management, including provider contracting, network strategy, credentialing, provider relations, and provider analytics. Having successfully navigated multiple network expansions across the Northeast, she has developed strategies and best practices around Medicare, Medicaid, and commercial networks. She has worked for health plans in the commercial and government program sectors, including UnitedHealthcare, Elderplan, Brighton Health Plan Solutions, Emblem, and Health Partners Plans. So Loretta, let's dive in. Could you give us just a little bit of an overview of provider delegated rosters?
Sure. First off, thank you very much for having me be part of the conversation. And I do think of this as a conversation about provider data rosters. I look at it, you had mentioned a holistic approach. So I have touched provider data and have kind of been a provider data nerd for my entire career, right from the beginning. So, I look at it as, here is a source of information that we're going to use for all of these different things, not just specifically for delegated credentialing or provider directory production, but for a whole continuum of things that we use provider data for. So, specifically today, we're talking about delegated rosters. So a delegated roster, you're getting this information from a health system. You're getting provider information, physicians, locations, all of this information. It's coming in a format, electronic format. Usually it's used to do the credentialing process, but it's also used to feed other parts of the system. If you're I don't want to get too far ahead of myself, but they're just mass listings of provider demographic information that you use to feed your system and to be able to have your end product, which I always think of the product that, at Health Plan we offer. The product is the network. So, that's kind of where I see the data come in. It's hard to manage them when, you've got all of these sources coming in different formats and everything. So, one of the things that we like to think about is, why are they important and why do we want them to come into the health system, its health plan in the format that they do? And, it's because they're coming directly from the health system. So they have the data, they're getting the data from all of the locations and the providers within the health system. So now we're getting one source of information, and that should be the source of truth. And that's why they're really important. And we're getting them more frequently now, I think. Over the last, I would say 10 years, we've seen delegated rosters, huge, massive lists of providers coming from health systems because of mergers and acquisitions. So you'll see a system like Northwell acquiring all of these groups around it up out in Long Island, or a system like UPMC here in Pennsylvania, where they're getting hundreds of offices and thousands of physicians onto one roster. And that's taking up a lot of your network. That's a lot of your network at one by one, just kind of filling that space of your network. So it's really critical that you manage them well and you get them into your health plan as efficiently as possible.
Absolutely. And so you mentioned that they've been growing in importance because of acquisition and sort of the convenience factor too around exchanging data and the importance of them sort of as the self-attested source of truth for provider location information, and getting that data into the health plan efficiently is really important for accuracy for the directory and the claim system. And just a bit of background why we thought this would be a fun conversation to have. Convergent, we recently launched our delegated roster management module, and Loretta interacted somewhat with that post that we launched with on LinkedIn. We had a conversation around that, and so that sort of spawned our relationship actually. And if anyone wants to stick around towards the end of this conversation, we'll do a bit of a demo of that if we have time. But until then, let's dig a little deeper on delegated rosters and talk about some of the challenges that health plans experience bringing in this data.
Sure. So, I think, again, to go back to the volume that we're getting here. So we're talking about not just one roster coming into the health plan. We're talking about rosters from every health system that they have a contract with. So you might have, 5 to 40 rosters coming into your health plan, depending on your geography and, what products you have out there. And there might be different rosters. So you might have a Medicare product that gets you one roster from a health system, Medicaid product gets you another. So now you've got multiple rosters coming in. And one of the challenges you have is how do you intake that? How do you validate the format? A lot of times, health plans are manipulating the data format to get it to either upload into their system or get it in a user-friendly position for entering the information into the system. And you want to make sure that they're complete. So, at times you have to reconfigure the data, but there's a lot of activity around validating the data. So, are the NPIs correct? Do we have all the specialties? Are all the fields completed? Do we have all the information we need, and is it accurate? So those are some of the challenges that I think you see in the health plan. And, I can think of a couple of examples, I can think of a lot of examples, but for directory production. So let's just talk about, you're using this data for directory, and it's a challenge because CMS has been putting pressure on health plans to ensure that those directories are accurate and they're timely. I think right now it's like from the moment you get it, you have 48 hours to update or something.
That's right.
Like really, really challenging. So you got to format it, validate it, and get it out there within like 48 hours for a directory. And another piece of this that I mentioned, because again, looking at it from beginning to end of the process as a person who does contracting, I'm also at the end of the process, if something doesn't pay correctly, I'm going to hear about it. So it's, if you've got a data set in your system that doesn't match what the provider's billing, you're going to have claims problems. Like the MPI could be group versus individual. You could have a specialist loaded as a PCP, and that's going to kick out your benefit design for your membership files. So you're going to have mispaid claims if that data isn't correct. So these are some of the challenges I think that most health plans face. And sometimes they have a department dedicated to this to spend it, depending on the size of the health plan and what resources they have available to them. Sometimes there are whole departments doing something, or there's just like this one person who's really good at like cleaning data or validating data. So that becomes cumbersome in the health plan setting for sure. So there are a lot of challenges when it comes to that, and you're thinking about it coming in at least quarterly, if not monthly. So all of those spreadsheets are coming in, validation, all that stuff on a monthly basis. So it does become like this constant validation and reformatting process.
Yeah, and we're seeing some health plans have sort of designed their own processes around that. And some of them still involve a lot of manual intervention. in order to do
Oh
that.
yeah.
And meanwhile, you do still have sort of this feedback loop that has to occur between the plan and the provider group who's submitting the data if errors are identified. So that can create some challenges to updating the information as well. So, we're seeing this really as an opportunity to automate some of this stuff using these best practices. Do we want to mention briefly sort of the ingestion of the files into downstream systems and sort of the matching that has to take place? I know you touched on that briefly.
Yeah, I touched on that briefly. I mean, you're at the health plan. You're going to either manually be uploading files or manually entering files, and you've got multiple systems. So you've got a credentialing system that's doing the credentialing. You've got a claim system that's doing the claims. You've got a directory feeding the system. You've got on the front end of everything, you got a contracting system. They're going to run it through the Quest analytics and all this other stuff. So when you get those files, all of those functions have to happen. So part of that ingestion and matching is you want to make sure that you're not overlaying good data by uploading data that you haven't checked to see if a provider's already in the network, if you've got them loaded differently because you manually found out that they weren't at that location or they didn't have that specialty or the phone number was wrong. Like, you don't want to just overlay good data with bad data. So now you've got to do this duplication matching. So that also is part of the process for sure. And it's a big part of the process.
Oh yeah. So, and part of the reason that I wanted to have you on, Loretta, is because I think your perspective is, like you mentioned earlier, not just around credentialing. And so let's talk about the impact of these rosters on networks and contracting, because I think it's really an overlooked area at times.
Yeah. And, one of the things that when you're starting a contracting and expansion campaign, you're going to want to see who you have in your network right now. Do you have an adequate network in those spaces that you want to go? So part of that process is getting these rosters. You get these rosters and you upload them into Quest Analytics or Geo Access or whatever mapping software you're using, or even homegrown. Like I've worked at companies where a team of actuaries actually did a fantastic job of creating their own kind of mapping software. But it's critical because you need to know where your gaps are. And when you've got these delegated rosters, if you say you need a plastic surgeon in an area that doesn't have a lot of physicians, there are some surgeons there, but you don't have a plastic surgeon listed because your data doesn't reflect that one of those surgeons is actually a plastic surgeon. If that data is incorrect, then you've got a gap there and you're sending resources out to try to fill that gap. So those spreadsheets come in and you're using them as a decision-making tool. You're using them as a tool to show CMS or a Department of Health or whatever organization that you actually have an adequate network, that you're ready to go with this adequate network. So from the beginning of the process, when you make a decision that you're going to go into a county, you want to be clear about what you have and what you don't have, and then be able to scale your resources accordingly. So that's where like these spreadsheets really become critical at the very beginning of the process. And I'm calling them spreadsheets, but you can get them in various formats. But these rosters just come through that way. So like I look at it from beginning to end. The very first thing, if I'm approaching a geographic expansion, I'm going to look at what I already have, and then if I have a delegated arrangement, and they might have providers there, I'm going to ask them for the roster. If I'm approaching other health systems to bring in that geography, I'm going to ask them for a roster right off the bat. Because that is going to be my tool to say, can I do this? And if I can, what's it going to take to fill in the gaps that they might not fill? So.
Got it. Yep.
And I think a lot of people miss that in the whole delegated roster process, is that it is a decision-making tool right from the beginning.
Exactly. And so let's talk about, we talked a lot about some of the problems that we face and some of the challenges. What are some of your lessons learned and best practices that you've seen in helping solve some of these?
I think for me, like right away, one of the things that we do is we ask for rosters in the beginning, because you want to know what you're working with the whole time. So that is a best practice right off the bat. But I think having a format that works, I had mentioned you've got all of these different systems that need to get to receive this and ingest this data, creating a format that you're going to enforce and say, this is the format that we need the information in. Some health systems will tell you they can't do it or they won't do it because they've got other formats that, if like they're using a format at a larger health plan that they use for everybody. They're like, this is the one we use for everybody. But if you can get them to use your format, make sure you have it a user-friendly format that has as much detail as possible that you absolutely need. Don't muddy it up with information you don't really need, because that tends to muddy the waters a little bit. But be very clear, standardize your format, data dictionary, or some sort of how to use this format, how to, what I'm looking for in these fields, field descriptions. When possible, create a drop-down field. Suffix on a provider name is an easy drop-down field so that you're not getting like weird combinations that don't exist in your spreadsheet. So to be as clear as possible, how do you want your date formatted? How many characters do you need in the MPI field? All of those things with a formatted data request. Another thing to do, and this is kind of sometimes it's a hard sell, sometimes it's an easy sell. Include it in your contracting process. So if you're doing a delegated credentialing agreement, it's going to automatically be part of that agreement. If you're going to say, here's our file format, you're going to attach it, and you're both going to agree to it. Add it to that. Or if you have a master service agreement with the health system, you can request it in the master service agreement and say, here's the frequency in which I need the data, and here's the format in which I need the data. And maybe you could put some incentives around it. I don't know how successful you'll be in that, but it is something to try. But definitely putting it in your contract can help you, but be consistent with it, be clear about it. Otherwise you'll just get it when you get it. Yeah. And be consistent, be clear, and create a communication feedback loop. They're going to have their data people. You're going to have your data people. Make sure they talk to each other and get back to them as quickly as possible, which is why I say from the beginning of the process, start asking for those rosters so that the teams can talk to each other and you can ensure that you've got the most accurate, timely information that you can from a health system. Another best practice is CAQH. CAQH was, it's out there. It's supposed to, in theory, it should be a great tool that you can just upload. You build a connection to CAQH, it's automatically going to do your data. There are some problems with it. It's not perfect. So, that didn't necessarily be the silver bullet that was going to take care of everything. But it can help you. It's just sometimes if you set up a direct feed with CAQH, it overlays your data. Providers are supposed to quarterly attest to it. They don't always do that, or they don't always re-review it every quarter to attest to it. So those are some things that might cause some fallout with CAQH. Another best practice is to invest in software cleansing, data cleansing software. Basically, you've got companies out there who can validate, not necessarily validate your data, but who can reformat some like Boulevard Avenue phone numbers, just cleansing your software, identifying where you've got like missing information. So cleansing your data, investing in a really good data cleanser. Some companies do data validation for you, so they might go to the NPAS, the NPPS system and validate NPIs. They might do some other forms of data validation for you as well. So I think researching that and getting the right software program for your health plan is a really good idea. Yeah.
Yeah, one stat that I noticed about CAQH is that I think 1/3 of providers in the United States are on CAQH, and that's a rather large number. I think it's over 1 million providers that would include, and that's great. And the downside to that is there's 2/3 who aren't on CAQH.
Right.
So it's a partial silver bullet, and it can be really a great tool. I'm a big fan of CAQH and what they're doing, but you do need to enable processes for provider groups who are not using CAQH. So that's where some of the what we see commonly is like an SFTP drop-off process, or even an email-driven process. What happens with some of those is that when you're living in an SFTP or an email-based threaded conversation, those can become kind of a black box at times. They're not really designed for this. So the benefit of CAQH is that it's really their delegated roster process is designed for this, but they don't necessarily reach everybody. So what we're looking at doing is, I don't want to show off too much of this just now, because I want this to be more of an informative conversation, but is basically creating a non-CAQH alternative that enables some of this feedback and direct feedback between the data submitters and the health plan. And I think that's one other best practice I want to add here too, is enabling feedback as quickly as possible. Because if you're waiting, every month or quarter to work these files, and you're providing feedback, sometimes weeks, months later, that can get out of sync with the next data submission. So how do you manage that type of communication effectively? And I think software can help do that.
Absolutely, yeah.
Yeah. Okay, so let's see where we are. I think we might be in the Q&A section. I see we've got a bunch of folks on the webinar currently. If there's anybody who has some questions or comments, please add them in the webinar chat. Oh, it looks like some folks have done that in the Q&A section. Let's see about this one. How do you address groups that want to submit updated rosters as a list of adds, terms, changes versus full roster updates? That's a good question. Loretta, do you want to handle that one?
That's a very good question. I think that you definitely do want to have that as part of your process. So you've got what you want to do is request a full roster, but you also want to have other rosters that these are just the adds, these are just the deletions, and these are just the changes, because you want that source of truth, that resource, that full resource. But if you have a system that you need to go in and manually do things to, knowing what is changing is extremely helpful, because if you overlay something that you just, you don't want to overlay something that might be correct already with something that's not. So you want to, I say always request that they give you separate files for that.
Got it. That's definitely one way to do it. We've seen a couple scenarios play out where, there's just a column that includes what the plan's asking you to do, or the provider group is asking you to do. But ideally, you want a software that can either take a full upload that would then essentially be a point in time copy of the source of trust or the latest and greatest data that would then
Right.
potentially overwrite all of that group's information. That can work. So
Oh, yeah.
the assumption is that, whatever is sent, that is the provider group at that point in time. But ideally you can have software that does enable, ads, terms, and things of that nature.
Right. Some
All
sort
right.
of notification coming from them, what they're sending you and why it differs from what you had the previous submission. So whether it's a column or a separate file, however it works for your health plan.
Absolutely. All right, so we're getting some more questions trickling in. This is from David Finney, one of the other co-hosts here. Loretta, do you ever see a future where the market moves away from managing rosters entirely, where the provider orgs and plans exchange data in real time? That could be cool.
Yes, that could be very cool. And I think that is like what everybody wants to do is the provider can directly go in, or they can directly go in and just enter it kind of in a feed directly to the health plan, and there's not this roster back and forth or this overlay of files. It'll just come directly from the provider, where the provider has access to update their own data and it's valid, and you can, I think it's going to happen sooner rather than later because of everything going on in the thought processes around interoperability and timeliness of data and holding everybody accountable for what is accurate data. I think that's a great
I think
thought.
we're in agreement on that, Loretta. Another good question from Jacob Tahan. Hope I'm saying that correctly. What would you recommend for your first steps for implementing a new delegation process in your organization? We have never delegated before, so we were trying to make sure we follow best practices in the process.
I definitely think, wow, there's a lot to that. Actually,
Yeah.
you want to, write your policy and procedure, get that tight internally, and how you're going to monitor the delegated entity, and NCQA, great guidelines around delegation. But you definitely want to make sure that you have a really clear PMP internally where somebody can just walk in and know exactly what that process is. And then you want to make sure that you're getting, you set up maybe a pre-delegation audit to ensure that the health system that you're delegating to can actually perform the delegated functions. And then you do your audit, and then setting up those processes, again, going back to enforcing some sort of format and time frame with which you'll get information from the provider, from the health system. I hope that answers your question or helps.
Yeah, I think there is a lot to that. It's and the good news is there are folks out there like Loretta who specialize in this type of thing. So there's consultants that can be brought in to help set these type of processes up. Loretta, I don't know if that's something that you're looking at doing, but
maybe. I mean, it is something that, like, right from the beginning, I remember many years ago, we started the delegation process, and this was a long time ago, but it was, we looked at NCQA. We got the NCQA book. That's how long ago it was. And we were just like, okay, what do we have to do here? And it was really about having a PMP that was very tight and adhering to that PMP, and making sure that you're delegating to an entity that can do delegated credentialing.
Right. Okay. So Arjun, I am going to show you an example of a delegated roster. I've got one pulled up here briefly, but before I do that, we've got another question. What advice would you give to smaller new plans that don't have as many resources or infrastructure as the bigger plans?
Wow. Okay. Yeah, that's a tough one, because again, you want to make sure that you have a system, like a credentialing system, a provider data management system in place that if you're a smaller plan, you don't have like this big arm of data entry people or this big arm of data people. You can ensure that the technology you have in place can automate things when you're talking about these large rosters, you want to be able to automate that. So I would say be very, conscious of which systems you're using internally to process these files. And definitely take your time around your credentialing criteria and your credentialing team. Focus on supporting them through the process. I mean, that's another a question that has a lot of detail behind it. So, you got to think about scalable resources and how you can automate as much as possible is what I'd recommend.
Yeah, I'd argue that in the smaller plans, automation's more important, where you don't have as many bodies to throw out a problem.
Yeah, you're absolutely right.
Luckily, there are software solutions like Convergent that are accessible by some of the smaller health plans. That's honestly one of our niches, is focusing on regional health plans who need automation. So why don't we can still have some Q&A trickle in as we're doing this. I'll share my screen because I want to show Arjun just a sample delegated roster. This is a pretty good one. Let me share my screen here, and then I can get into a brief demo of our delegated roster management module and do that. So let's pull that up here. Loretta, let me know if you can see my screen.
Okay. Yes, I can see your screen.
So this is a sample from Montefiore. I've blanked out all the social security numbers, so nobody can steal those. But generally, this is a pretty common format for what we see. And you can see that this is an ad provider request. And typically, another thing that we see is each provider is broken out by location. So this provider, looks like they have 1, 2, 3, 4, about 8 locations here. And then you're getting really valuable information off this roster, like their MPI, social, date of birth, Medicare, Medicaid IDs, license IDs, their expiration dates, taxonomy codes, specialties, whether they're board certified or not, the certifying board, etc. Obviously, another big one is the TIN, the group name. Here we have the address information. This address data looks fairly good, but good software that's taking this in should have USPS standardization built into it. Also, billing locations and ADA compliance data. We're seeing that as a more common thing, whether they're accepting new patients at that location, whether the exam room's ADA compliant, what type of ADA compliant equipment there's there, and then the office hours. These office hours can be sort of a tricky format thing at times. There's not great standards around it right now, but yeah, that's why it's really important to sort of generate your own standards, because these can really, fields like this can create a lot of headache for the data submission process, whether that's automated or manual.
Yeah, that actually gave me a slight headache, because I remember dealing with that in the past with the hours of operation being hard to format.
Yeah, absolutely. So we've helped some of our clients design processes around, well, at least standards around some of these non-standardized fields. So I'm actually going to now move to our demo. Anyone who's not interested, feel free to drop. It should be only a few minutes. I'm actually going to share this link out in the chat after we hang up, because it's a public demo for our roster management tool. But instead of a email or SFTP, which can be good, and if you automate them properly, they can be super handy. What we've created is sort of this common roster upload tool, which uses a lot of the best practices that we've talked about today. So one of the first things that you can do is download a sample. So once I've got that, I'm essentially asking the health system to either use that sample or upload their own file. Once they've done that, they can preview what that file is. I've got a pretty small 12 provider list here, just for an example. The next thing that can be done is mapping the file columns of the submission data of the roster to the normative field names that we've defined behind the scenes. So we can sort of set up whatever those field names are. And if the group follows the template, they will auto map. If they did not auto map, it will essentially ask them to select which of their fields match the template. So, you can have one of these, roster upload templates, or many, depending on how many groups that you want to sort of enable here. So let's go ahead and select group name here. I'm just going to check and make sure all of my file columns match up with my destination columns. So this looks good. I've done this a million times, so I know it works. The next thing that you're going to get is that instantaneous feedback. So the provider group, who's ever submitting the data on their side, is going to see essentially an error report. So instead of us having to wait for the SFTP to do its thing and some person behind the scenes maybe generate this or pick it up back in my email, I get a handy user interface to see, okay, what are my data issues that the plan is asking me to fix? So I've set some examples here. This is a required field, so I'm going to make sure that I have that entered. And then my date of birth, I've actually required a specific format for that date of birth field. So now those are correct. I should be able to submit. One thing about this is that each field, we can set very granular definitions of data conformance behind each field. So things like field length, field values, required fields. We can even integrate with the Convergent API to do validation on this for things to like NPI to make sure that it's a legit NPI. So now that all of my data is conformant up to the health plan standards, I can go ahead and submit. Once that data has been processed, then we push it down into different, any system really that a health plan might have where that data needs to go. A lot of times what we do for our clients is we first pass it into our provider data hub, where we can do things like Loretta mentioned earlier, like matching and enrichment. So what Convergent does is we're monitoring all of these data roster submissions, and then inside of the data hub, it would probably take a little bit longer for me to give you a full view of what everything Convergent does, but we take those rosters in, we match them, we deduplicate them, and then we send them to the claim system, the directory, wherever that good clean data needs to go, automatically via API or sort of a bulk CSV process. And I think I've mentioned it briefly, but inside of Convergent, we have a lot of reference data, things like NPES, DEA, Medicaid files that, if the provider group didn't submit it properly or all of the information we need, we can still accept that data up to a point and enrich that and add in that useful information that the claim system needs or the directory needs. We're also doing, USPS address standardization, etc. There's a whole lot to that there, but mainly what I wanted to show you is the delegated roster functionality where we're enabling sort of that submission of data. Looks like we have a few more questions here. Before we wrap up, if organizations are delegated, do you find their providers are also in/up to date in CAQH? That's from Jessica Hess.
They are usually in, if they were in before the providers have their own NPI. And so they're in CAQH, but they might not always be as current, or sometimes they're off sync with what's in the roster. So
So generally you're seeing the rosters as more of the up-to-date data.
Usually, yes, but I could be wrong. It depends really on your health system and your geography.
Got it. Okay. Arjun, I have a question here from Arjun. What language does this tool run on the back end? I wish I could tell you, but I am not the developer that helped build this. So we can have a follow-up conversation later if you'd like to ping me. I'll drop my email in the chat. Okay, I think we have a couple more questions. Let me see if I can find those. Sounds like a technical question for you, Loretta. Do your DUAs allow for resale of the delegated data to third parties? Actually, I think that might be us, delegated use agreements, data use agreements. I don't know. We typically we can determine what our data use is on a per case basis, so that the product itself can lock down data to keep it private so it's not shared, or vice versa. So we can enable the sharing of data, and we do that via API. But yeah, our data use agreements are on a per case basis. So hopefully that answered your question. David Finney, if one of the partners and founders here, might have to jump in and correct me if I'm wrong on that, but he's really the man behind a lot of that. Do you contemplate having population data around the location of the practitioner for health equity, risk score calculations, etc.? That's an interesting one. Loretta, do you have anything on that?
Yeah, I mean, I think that goes back to, when you're doing your geo access or your Quest Analytics piece of, do you have the network that you need? So there's the network that's adequate for any type of regulatory agency, but then there's the network that you want in place, and understanding if you can get a good data file of membership that might be blocked off, but you have like age and gender and all of that information in a file format, you can lay that up against your network or up against a roster and see how that plays out against the specialties. So that's an excellent question, and it comes into play a lot when you're doing value-based arrangements or population health, those types of things, as you're contemplating the SDOH initiatives that you need to perform at the health plan.
Yeah, and just to add on that too.
Let me rephrase that, not need to perform, want to perform, because you do want to get in those communities where you can do the most, and you want to make sure that you've got the resources there against the membership that you might have there.
Yeah, and what I was going to say, Loretta, is just to add to that, if you do have a software that can enrich providers, say a provider with a given MPI comes in that's at a specific location, what we're seeing is the ability from some enrichment software to add some of that granularity around that location to give you a better sense of where that provider's practice location is, and get a sense of more of the demographics of the patient mix surrounding that area.
Yeah.
But yeah, great question. And I love that question, because health equity is so important. And I think COVID obviously illuminated that even more and made that more important for us. But I'm glad that's becoming more of a topic of conversation.
Yeah, I agree completely.
Question from Chris Martinez. Is this solution offered for provider groups or just the health plans? We generally built this for health plans, but we are seeing provider groups ask us, hey, can we use this as well? So we're open to that conversation, Chris, and I think there are some good use cases for helping standardize and make the roster data more conformant across the board. So good question there. I'm not seeing any more. Well, I'm going to make this the final question. I'm loving how engaged the chat is here. MIPS bonuses will be based upon movement of baseline service utilization against certain targeted inequities. That's money for ROI. So I'm not sure if that's much of a question, Loretta. I don't know if you have a comment on that, but
yeah, because then Yeah, I can't tell what the question is there, but yeah, as you're, you want to reevaluate, you want to set a baseline and then show improvement over time to kind of target those inequities and see what results you're getting. Because it's one thing to just throw it out there and walk away, but I think the intent here is that you're going to start seeing ROI as you reassess that population against your network, against, some of the services and some of the options that you're putting out there. I'm
Great.
not sure what the question was though, so I'm sorry.
Yeah, no, I think you got to the heart of it though. Thanks, Loretta. Thanks for thinking on your feet on that one. I like the question though. All right, so I'm gonna wrap it up here. That was a really lively conversation. I really enjoyed it. Loretta, thank you so much for spending 45 minutes with us today. Thank you for all of our attendees for hopping on and participating in the Q&A. I hope everybody has a great rest of your day, weekend, and holiday season. So
thank you everybody. Have a great weekend.
All right, take care.
Thanks. You too. Bye.